programs that have been successful historically in providing infrastructure support for the state of California and the United States. Fourth, supporting existing healthcare workforce, revising funding allocations for centers of excellence, etc. Fifth, incentive payments for primary care and other services that are provided in health profession shortage areas. So again, the questions that we've been asked, how are we coordinating with other departments? Well, to focus the implementation of healthcare reform in California, the governor has created a healthcare reform task force. This task force is led by Secretary Kimberly Belshea of the Health and Human Services Agency. The Healthcare Reform Task Force is comprised of administration officials and agencies tasked with implementing the provisions of the Healthcare Reform Act. Within the task force, there is a Healthcare Workforce Work Group, which will focus on the training and workforce development programs in Title V. This work group is comprised of representatives of the Labor and Workforce Development Agency, Health and Human Services Agency, OSHPD, and the California Workforce Investment Board. I am co-chair of this work group, along with Barbara Halsey, Executive Director of the California Workforce Investment Board. We recently convened public and private stakeholders representing various state and local governments, local workforce investment boards, health professional associations, health profession educators, foundations, advocacy organizations such as the California Healthcare Workforce Alliance, for the purposes of gleaning recommendations from them, obtaining their feedback, and moving forward with a functional collaboration to make sure that we're able to pursue all opportunities that the state of California has. The work group is in the process of developing a comprehensive strategy to coordinate sharing of information and resources with public and private stakeholders to maximize the state's ability to draw down federal funds in support of healthcare reform in California. The work group is also examining, sharing, and coordinating, where appropriate, other funding opportunities with our state partners, as well as other public and private sector partners who may wish to submit applications in conjunction with opportunities in the Healthcare Reform Act. For example, last week, 2 weeks ago, the federal government announced $250 million in funding opportunities, $5 million of which will be allocated as planning grants for states to prepare a coordinated plan and strategy for healthcare workforce in California. OSHPD is working closely with the QIB in conjunction with the application, and will be calling upon other key stakeholders to support the planning grant. Then finally, the administration, that is the Labor Workforce Agency and the Health and Human Services Agency, will recommend an individual for appointment to the National Healthcare Workforce Commission later on today. The administration has solicited nominations from 15 organizations, and we received names of 13 candidates for evaluation. And so that appointment, that nomination, will be submitted later on today, and we will move forward seeking the appointment for the state of California. The second question before us is, we've been asked, what are the opportunities to expand and build on existing programs? Well, one opportunity that the state very much can pursue is to become a center for health workforce analysis as spelled out by the Affordable Care Act. And to do this, we can leverage one of the programs that is already in existence within the state of California, the Healthcare Workforce Clearinghouse. The Clearinghouse basically facilitates the enhanced data collection and closes the gap that we have in knowledge about the distribution, function, and demographics of our healthcare workforce within the state of California. Sharing data across departments is a major step forward and necessary to really evaluate the status of our healthcare workforce. Other opportunities include maximizing opportunities for areas in California that are already experiencing shortages in healthcare workers. Many of these areas are already defined as shortage areas. Many of them are not. And the Affordable Care Act does provide the opportunity to proactively designate shortage areas within the state of California. And we will be ardently pursuing that opportunity. Thirdly, we have a number of existing programs within OSHPD that are going to be enhanced by the Affordable Care Act. The first is the CalSearch program, the California Student and Resident Experiences and Rotations in Community Health. This is a program that aims to increase the number of health providers practicing in shortage areas by providing students with clinical experiences linked to preceptors, mentors, and projects throughout California based at community clinics. And we are part of a team comprised of the AHECs, the Area Health Education Centers, and the Primary Care Association of the State of California to implement this program. The second program will be the Saul and Brown program. This is a long-standing program that trains primary care healthcare workers in the state of California, nurse practitioners, physician assistants, registered nurses. All these education programs benefit from Saul and Brown funding. There is the National Service Corps, the State Loan Repayment Program. These programs will be expanded greatly under the Affordable Care Act. And we're looking forward to seeing more practitioners providing service in designated shortage areas in the state of California as a result of these expansions. The third question is, are we competitive? What are the challenges? Well, yes, as a state, we are very competitive. The administration has certainly formed the infrastructure necessary to move forward in this area. We will need to develop short-term and long-term plans for workforce development, but we cannot be successful, and I want to emphasize, we cannot be successful without our private sector partners in undergoing this effort. The planning grant opportunity that is immediately before us will certainly help us to engage these partners in an effective way to move forward in a collaborative and consolidated fashion to devise a comprehensive strategy for the state of California for workforce development. One challenge, as I've already mentioned, is the fact that we lack data. We really don't know who is practicing where in the state of California, except for some minimal professions at this point, 2 or 3. Without that data, we can't move forward in a very informed fashion, and this is what the Healthcare Workforce Clearinghouse addresses. And finally, I just want to close by saying that a strength that we have in the state of California that really ensures our competitiveness is the partnerships that we have with our private sector and other public sector partners, such as the University of California, the CSU system, and the California community colleges. We're working with the California Healthcare Workforce Alliance and other organizations and associations together to make sure that California is able to bring into the state every benefit that is made available to us by the Affordable Care Act. Thank you very much.
Thank you, Doctor. I think we'll afford the other panel members a chance to talk. I do have just one quick question I'm going to ask before we move on. You mentioned that we have the ability to designate or prioritize shortage areas. The we, is that your agency? Is it who has that authority to make that designation?
Correct. Essentially, OSHPD is able to nominate shortage areas to the federal HRSA, Health Resources and Services Administration, that makes the final designation for the state of California. We're one of the few states that actually has that ability.
And are you currently involved in expanding or developing a current designation of underserved areas?
Yes, this is actually an ongoing process that has been in operation for many years, and we are constantly striving to make sure that as many areas are designated as possible.
Is that data you can share with our office, just what's the current designation of shortage areas? I'd just be curious to see.
Absolutely. We would be
what
very
that
happy
map looks like.
To provide it to you.
Great.
Yes.
Thank you very much.
Thank you.
And we'll move on to Ms. Halsey.
Great. Assemblymember Monning, it's a pleasure to be with you today. I do want to make a correction. Secretary Vicki Bradshaw provides leadership for the Labor and Workforce Development Agency. I have the pleasure of serving as the Executive Director for the California Workforce Investment Board, so just wanted to acknowledge that.
Okay.
Again, it's a pleasure to be with you today and to talk with you a bit about the State Workforce Investment Board's role in collaboratively leading our response to healthcare reform and the demand created by that act. I want to start with some of the things that have already happened legislatively that really position the State Workforce Investment Board well for this opportunity. In 2007, SB 293 passed, and in that Act, the Workforce Investment Act in California, the State Board was placed in a role of lead for developing a statewide workforce development strategy. And we've been very fortunate in working with partnerships at the state level, at the regional level, and the local level as we approached doing a comprehensive strategy for workforce development. In 2008, AB 3018, the Green Collar Jobs Act in California passed, and the legislature put language into that bill that required the state board to use a sectoral strategy approach as we evaluated the workforce response to sectors throughout California's economy, the first being the clean and green economy. We've launched our Green Collar Jobs Council, and it's the first effort that the state board has made in really organizing a workforce response using sector strategies regional partnerships, and local delivery systems. I want to provide you just a brief introduction to sector strategies, and we've provided a fact sheet, economic competitiveness strategy. We really see sector strategies as a way to get to the root needs of critical industries throughout the state. They're particularly important because they depend on data. We're not just talking about traditional labor market demand data, which gives you an idea of aggregate occupational demand throughout the state. We're talking about pairing that labor market information with critical economic trend information that helps us understand how particular industries that are critical to California's economy are concentrated in particular regions, and then allows us to take a deeper dive into that data and understand what that means in terms of workforce preparation for agency or for our businesses. We were fortunate this year to be able to launch regional industry clusters of opportunity grants, and currently throughout California we have 10 collaboratives. Those 10 collaboratives are led by Fresno County, which is a collaboration of Amador, Calaveras, Fresno, Kern, King, Inyo, Madera, Mariposa, Merced, Mono, San Joaquin, Stanislaus County, and Tuolumne. They're focusing on a targeted health sector. Humboldt County received a grant, and their collaborative includes Del Norte, Humboldt, Mendocino, Siskiyou, and Trinity counties. They're focusing on health, the agriculture industry, building and construction, and environmental science in their regional economy. The Northern Rural Training and Employment Consortium consists of Butte, Del Oro, Lawson, Modoc, Nevada, Plumas, Shasta, Sierra, Siskiyou, Tehama, and Trinity counties, focusing on health industry needs, energy efficiency industries, energy generation industries, information technology, manufacturing, and transportation. The North Valley Job Training Consortium is a consortium made up of Santa Clara and San Mateo counties, focusing on health, information technology, and the convergence between health and information technology. Our San Diego partnership is focusing exclusively on San Diego County, focusing on health, information technology, and again, the convergence between those two industries. Pacific Gateway is a consortium that includes Los Angeles, Orange County, and Ventura counties. Their focus is on the energy efficiency industry, green building, recycling, transportation, and the water industry. Sacramento Employment and Training Agency is a combination of El Dorado, Sacramento, Sutter, Yolo, and Yuba counties, focusing on energy efficiency, energy generation, energy storage, green research, and smart grid industries. Santa Barbara Consortium is made up of San Luis Obispo, Santa Barbara, and Ventura. They're focusing on the agricultural industry, energy generation, energy efficiency, green research, resource conservation, and transportation. Contra Costa County, as our last consortia, is a collaborative effort between Alameda County, Contra Costa, and Solano counties, focusing on energy generation, energy efficiency, energy storage, and water. And I appreciate you giving me time to go through those collaboratives because I think it really sets the stage for the remainder of the conversation that I'd like to have with you this morning. We understand that California is made up of many regions and many regional economies. We believe that by going out and working through these consortia of counties that come together to understand in a very data-driven way what's going on within their regional economies, and then layer it with identifying the workforce needs associated with those drivers of their economies, we're going to do a better job of leveraging the investment opportunities that are available, of making sure that federal funds coming through the state and down to those local areas are utilized appropriately, of engaging with our education system, K-12, community colleges, adult ed, ROCPs, and our university system in order for them to understand how they can align the kinds of training programs and educational tracks that match best the employment opportunities that are represented in that regional economy. So we're really excited about this formative work that we're doing. And we believe that the groundwork, the framework that we've laid will serve our efforts under healthcare reform very well. I want to talk with you just a bit about how the regional planning initiatives and sector strategies will help us with healthcare. Because we've already launched our regional planning initiatives, we already have 3 areas at a minimum that are beginning to focus on what are the healthcare needs of their regional economies. And we believe we're going to get some early information from those areas about the potential impacts or the multiplier effect that healthcare reform may have on workforce demand within particular occupations in the healthcare industry. We believe it's also going to help those areas identify where they may have economic gaps or where they may have service gaps in their healthcare delivery system that they need to pay particular attention to so that they're prepared when 2014 hits. We know that by bringing together this multi-sector education, economic development, workforce development, and the business community, by bringing together this kind of collaborative, that we can encourage joint priority setting. And we think it's critical if we're going to ensure California's economic competitiveness into the future. We have to begin talking together about solving complicated issues within our state's economic infrastructure, and workforce development is one of those conversations. We also believe that by doing it in this way, we can design leveraged investment strategies where funding coming in through health and human services agencies, funding coming in through workforce agencies, potentially funding from private businesses and from foundations can really be used to get to solutions around the workforce issues that are prominent within those regional economies. We also believe that by focusing efforts at the regional level and using appropriate local delivery systems, we can begin to do a better job of planning for sustainability. So if we're providing seed funding for projects, those regions, those local partners are really considering what they need to do to sustain the effort for those critical industries on a long-term basis. I want to talk about some of the similarities between healthcare and the green economy. One of the things that we saw with clean technology and the green economy was very policy driven. With the passage of AB 32, the renewable portfolio standards, with California's long history in climate action, we understand that the green economy is evolving, often because of regulations that are coming out of those policies. Federal healthcare reform is doing the same thing with the healthcare industry. We know we've had a long-term healthcare workforce shortage. Healthcare reform amplifies that shortage. We need to understand where policies, as they roll out from the healthcare reform legislation, how they're going to be implemented, what the impacts are on providing services to individuals, and what that means in terms of new workforce preparation, potentially new occupations that will emerge as we try to address shortages by using technology in new ways. We also understand that there's greater need for coordination among public and private partners, and we absolutely must leverage our resources in an era where we're understanding the state budget is more and more tapped, and where people in their personal lives are feeling the stress of lack of income because of joblessness. Our ability at the state level to effectively be good stewards of the resources that we have available and make sure that those dollars are doing the most for those communities and the most for those individuals who want to reemploy is really essential. We also believe that, like the green economy, we need to approach this from a data-driven perspective. We need good information in our hands to make decisions, and we need to make those decisions with a broad base of stakeholders at the table. Industry-focused strategies really allow us, sector strategies really allow us to engage with the industry in a more meaningful way. Workforce is one of the issues that healthcare has. There are a multitude of issues in the healthcare industry that we have to be ready to side-by-side address with them. So bringing our economic development partners and our other agency partners to the table, along with private business, gives us a better understanding of what the larger issues are for that industry. So hopefully we're solving workforce problems along the way as we're addressing other issues that may impact the industry's ability to meet the requirements under healthcare reform. We also know that like the green economy, healthcare requirements are going to vary region by region. So it's really important that we understand whether we're talking about an urban area, a rural area, or what may be defined as a frontier area. What's the need? What's the demographic impact of the individuals who will be seeking and using this reformed healthcare system? What do we need to do in order to staff up? Where do we have gaps, as I said before, in the service delivery mechanisms? So it's really important that we look down to the regional level and down to the local level at what the needs are going to be for particular sub-sectors within the healthcare sector. We also understand that there's a breadth of opportunity, as in the green economy, for individuals with a variety of educational backgrounds. And we need to be very conscious and very conscientious about our attempts to connect our education pathways. So if someone is coming out of a high school program or a healthcare academy, they can easily enter into a community college program. There are a lot of things that we need to do with articulation between our educational institutions, and we also need to consider how apprenticeship might be used in the healthcare industry, and that's a bit of a new concept for healthcare, typical in some of our trade occupations, but we do believe there's opportunity to expand the use of apprenticeship within the healthcare arena. So our challenge is, how do we begin to structure credentialing programs, stackable certificates, so that people can come in and out of educational opportunities and advance within career pathways within the healthcare industry. And we believe that reform is going to give us the opportunity to have some of those conversations. I do want to provide you with just some quick information on some of the challenges and opportunities that we see. I don't want to take up too much more of your time. We understand that a mandate for healthcare services to some potentially 8 million new customers within the healthcare arena is a burdensome task. And if we aren't careful, and if we aren't collaborative, and if we don't partner as we approach this opportunity, we could make some missteps, and we don't have time for that. So the California Workforce Investment Board's intent is to work very closely with the Health and Human Services Agency, with the Office of Statewide Health Planning and Development, other partner agencies, the private sector, associations, and foundations as we approach a comprehensive strategy for the implementation of healthcare reform in California. It's an enormous opportunity. It comes at a time when this state has upward of 11% unemployment rate, so it also holds great opportunity for those Californians who are really looking for an opportunity to return to the workforce, to hold on to their houses, to be able to support their families again. And it's incumbent upon us that we develop a strategy that allows them to move into training and into occupations that will be presented as we expand our healthcare system. We have to look at new ways of educating and new ways of connecting our education systems. So we have to have a very deep conversation with our education partners about articulation agreements between high school, community college to four-year institution, and recognition of prerequisite training between institutions that currently present some problems throughout the state. We need to clearly give good regional data to our partners at the regional and local level so they can make educated decisions in partnership with the critical partners at the regional and local level to plan for what healthcare reform means in their areas. We're intending to aggressively apply for all of the funding available. We're currently working on the application for the planning grant with the Office of Statewide Health Planning and Development. We're engaging partners in that process. Our intent is much like the structure of the Green Collar Jobs Council, that will have a special counsel under the California Workforce Investment Board that will oversee and guide how we approach healthcare reform workforce development throughout the state. We're talking with our partners now about what that should look like and how we can meaningfully engage all of them, and we look forward to continue to work with you and update you on our progress.
Well, thank you very much, Ms. Halsey. I do want to just acknowledge we've been joined by colleagues, Assemblymember Nastandi and also Assemblymember Perez, and we've heard from Dr. Carlisle. We've just heard from Ms. Halsey with the Workforce Investment Board, and our next speaker will be Director Brian Steiger with Department of Consumer Affairs. And just before we turn to you, I did have a quick question, then maybe after Mr. Steiger's testimony we can open it up to other questions as well. Just, Ms. Halsey, you mentioned that in 3 regions you were looking at healthcare workforce needs. Do you know which regions those are?
I do.
And while you're how many regions are there total?
We have 10 regions currently funded to do the regional industry cluster of opportunity work. Fresno County is focusing on health. Humboldt County is focusing on health. The Northern Rural Training Consortium, which is Butte, Del Oro, Lawson, Modoc, Nevada, they're focusing on health. So actually we have more than 3. We have 3 that were primarily funded for health, but as we started going through the diagnostic, more areas identified it as a priority. Our Santa Clara San Mateo partnership has a health focus, as does the San Diego partnership.
Great, that's helpful, and I think maybe when we open it up to more questions we can come back to this, but I guess one of my concerns is that we're not starting on an even playing field as the national health care reform comes into place. We have 8.2 million Californians without health care coverage. We have insufficient capacity to meet existing covered individuals, and now we're going to jump a huge new number of eligibles, and yet we're already kind of in a crisis mode. So I'd be curious how we might be able to encourage all of the regions to at least have a component of their work focused on healthcare workforce needs and development. And perhaps the ones that are doing it will provide some pilot-type templates or formats of how they're approaching this. But it seems like it might be a good objective to have all regions have this be part of their prioritization over the next year. Is that possible, do you think?
One of our goals, we first need to complete the application for this planning grant. Once we apply and receive the planning grant, it opens the door for implementation funding to come from the federal government. And our intent, again, is to apply for that implementation funding at a level that will allow us to dig deeper into those other regions where we haven't currently got efforts underway. I will say, while these 5 regions are doing the work in healthcare as a part of their regional industry cluster of opportunity grants, there are already great efforts going on at the regional and local level with other workforce investment boards outside of this particular planning opportunity. So I think we have a cadre of folks out there who are already considering this, looking at what they need to do, and they're doing so because they have huge numbers of people knocking on their doors looking for new training opportunities and new careers.
Great, thank you. And again, there may be further questions, but I do want to afford Mr. Steiger the opportunity to share his testimony, and then we'll see if there's further questions. Welcome, Mr. Steiger.
Good morning, Mr. Chair, committee members. Brian Steiger, Department of Consumer Affairs. The Department of Consumer Affairs has 18 healing arts boards who license and regulate about 1 million healthcare practitioners. And so with the new federal healthcare reform, we are preparing ourselves for the enormous workload challenges that are going to be facing us. Licensing, for example, we want to make sure that at the department that folks that have met minimum qualifications and have passed all their national exams and state exams, that they're able to begin practicing as quickly as possible. So right now we're in the process of trying to reduce and eliminate most of the licensing backlogs that we have, and we have made significant progress on that. But as we move further along, we want to actually take a more concentrated look at licensing reform to make sure that there are no artificial barriers preventing folks from entering the workforce as quickly as possible. And we want to do all that and keep the application fees and licensing fees at a reasonable cost. We're also going to work with other boards from other states to streamline reciprocity. There may be healthcare practitioners out in other states that want to come to California and work, and we don't want to provide any or create any artificial barriers from that. So our job right now for licensing is to be proactive. We know we're going to have a lot more folks coming on board, and we want to make sure that we are not an obstacle for them to begin practicing. Secondly, there is going to be an increase of the number of consumer complaints that we get. Right now, we have our Consumer Protection Enforcement Initiative that is moving forward. We are preparing ourselves for this additional workload with regards to complaint processing and investigations and prosecutions. Currently, probably 95%, 97% of the healthcare practitioners that we have right now in California do a fabulous job. But those that don't, we want to be able to make sure that we're protecting consumers. Data collection, we're working very closely with Dr. Carlisle's group to provide data collection with all of our healing arts boards to assess where those workload and workload challenges are. We're going to continue to do that. We worked closely with Dr. Hernandez on his bill last year to address some of the concerns that we have, and we're looking forward to working closer with him as he moves forward. And then lastly, we do have the Bureau for Private Post-Secondary Education. Healthcare reform is going to have an impact on this particular bureau. Experts predict that even with expansions, existing public and private colleges and universities will not be able to handle the increased number of post-secondary students over the next decade. This applies broadly to health-related training and to non-health-related training. It is likely that private for-profit colleges and training programs will play an increased role in educating the next generation of healing arts practitioners, and our Bureau will be the state entity that licenses and regulates these schools. The existing Bureau was established about 6 months ago and replaces a program that was plagued by a number of deficiencies. The establishment of quality educational programs for healing arts practitioners that train them exceptionally and also treat them fairly as students will be a vital mission for the Bureau. As this Bureau gets up and running, I will ensure that special attention will be paid to new healing arts training programs. I'm looking forward to working with you.
Thank you very much. And it's Mr. Steger, is that
yes.
correct? Sorry for the mispronunciation earlier. I'm just curious, when you talk about healing arts practitioners, what's under that umbrella when you say
includes physicians and surgeons, dentists, acupuncturists, physical therapists. We have
chiropractors.
Chiropractors also. The Board of Chiropractic Examiners is not actually in the Department of Consumer Affairs, but we work very closely with them.
Mm-hmm. Great. And then related nursing. Did you mention nursing?
I didn't, but we have registered nursing, vocational nursing, nurse practitioners.
Mm-hmm.
We regulate there's about 200 professions of the department, half of which are healing arts boards.
Great. Yeah. Well, thank you very much for your testimony as well. Let me see if my colleagues have any questions for any of our witnesses. Mr. Perez.
Chair. Well, thank you, Mr. Chair, for this hearing. I appreciate it, and thank you all for being here as well and presenting this morning. Just like to know a little bit more about your licensing reform that you had mentioned. How long does it take currently for someone to be licensed? And what would be some things that the state legislature can do to better support you, to streamline the process, as you stated? What does that streamline look like?
Well, each board is independent, and so we don't have an actual number of average days for everybody. For example, the medical board. In statute, they actually have time frames where they have to review and process applications. I believe they have to review their applications within 60 days of receipt. But folks have to take exams. They have to go through background checks. There's several different levels that they have to meet before they actually get licensed. What we're asking all of our boards to do is take a look at their existing statutes and their regulations, and just to make sure that if there's anything in there that has delayed the process over the years, let's take a look and see if we can make some changes to shorten up that time frame from when folks apply for jobs or apply for licensure until they actually get their license. We're just in the initial stages, in the early stages of this. We're we're going to put a plan together probably in the next 60 days to present to the administration, and we're hoping that our boards will begin to promulgate regulations or certainly propose legislation within the next 90 to 120 days.
Well, thank you for that. I can appreciate that. Coming from a medically underserved area back home in the eastern Coachella Valley as well as Imperial County, obviously, like many areas throughout the state of California, we're lacking everything you can think of. Dentist, specialty care type of specialty care type of doctors, preventive medicine as well, outreach workers, so on and so forth. And so, for me, one of the things that I think is critical in this movement, if you will, is obviously making sure that we prepare our workforce on one end, but at the same time, if there's ways in which we can minimize the barriers that may come before us so that we can get people to work, and as well, which would help our economy on one end,
yes,
but as well provide a better quality of life for our constituents, then I'm all for that. So I'm looking forward to that report and looking forward to other thoughts and ideas as to how the state legislature can support you when it comes to licensing reform. If I may, Mr. Chair, I have another question, perhaps for Ms. Housey or for whomever in the panel. The issue of articulation. You touched something that I think is critical. We talk about articulation so often when it comes to our K through 12 system and the fact that we need better articulation there. We talk about it from the aspect of K through 12 connected to our community colleges and then K through 16, and which is very, very critical and I think is important. But too often we do not discuss articulation between our school systems and our business community. And our school systems, and for example, if we have a health academy or one that wants to create a health academy, what are the links to the health clinics in the nearby area so that we can really create a career pathway that is hands-on, authentic learning, if you will. And so I wonder what your thoughts are, Ms. Housey, with relation to articulation between our business community and our education community. I think I think there's a gap there, but wondering what you happen to say about that.
Assemblymember Perez, I would agree that I think they speak different languages. And to some extent, I really see the workforce investment system as potentially the translator and the mediator between the education system and the business community. And we've seen it occur over and over again. When you bring people in around a community issue, when you lay in front of them the data that speaks to critical needs within industries that are critical to their regional economies, and you get them problem solving around that, they develop a different way of talking to one another. Mm-hmm. So in the work that we've done with the Green Collar Jobs Council, mm-hmm. the partnerships we've created on the regional level and on the local level have connected education and business in new ways, have allowed them to begin to see each other as partners in the same game, mm-hmm. Rather than business saying education isn't providing the kind of workforce talent that they need, and education saying that they don't understand the needs of business. Facilitating that kind of conversation is really, I think, an opportunity that we have. That being said, yesterday and the day before, the healthcare career academies were in Sacramento, and those high school teachers and business leaders came together to talk mm-hmm. about what was working within those academies. We had a chance, some of the workforce investment people in the state to do a panel with that group, and it was amazing to me that even though we've encouraged the connection to business, there is still a lot of work that needs to be done. Even though those healthcare academies are relevant within their local their local economy and have the support of education providers, they don't necessarily have that connection to industry. So we talked in those sessions about, well, what can we do as the State Workforce Investment Board in connecting those academies to local workforce investment boards so they have a better connection to the employer community. So those are the kinds of conversations that need to be ongoing and will have to happen over and over and over again for us to get it right.
Appreciate your points, Ms. Housey. I like to engage further in this discussion and learn what the lessons learned are and what the challenges are that you face and what the folks on the ground are having to say about all that. I mentioned earlier that I come from a medically underserved area, but being there, I actually had an opportunity to work for a clinic and at the same time be a school board member. And so I saw both sides, if you will. Definitely advocating that we have linked learning or stronger ties to hands-on experience for our students where they receive the theory, perhaps in the classroom, and get the practicum on-site within a certain industry, whichever that may be. But there's still much to be learned from that, I think. And I also think that those models that exist, and I'm sure that there are many successful models, definitely need to be integrated in discussions that we're holding now outside of this committee, but committees that are dealing with the multiple pathways, career pathways. Just yesterday, for example, I wasn't able to attend, but our Assembly member, Mr. Torlakson, had a hearing within, I think it's Communities and Schools, where he was talking about this as well. You know, the master plan for higher education, we have a select committee on that. I think some way, somehow, we're all trying to get to the same goal, but we got different processes, different stakeholders, different committees to try to get us there. Somehow, some way, if there is one, that we got to somehow bring it together and create a unified vision. I think that we have too many youth currently that are, dropping out of school, and that could be for many different reasons. But I know one has to deal with the fact that education for many of them no longer is relevant, and I also think that one way we can make it relevant is by encouraging career technical education, and with that being linked, for example, to this issue we're talking about, the health disparities or the professions that currently we're lacking in many underserved communities. So with that all being said, I look forward to those lessons learned and challenges. Like to learn from that. Like to see that as a model throughout the state of California, quite frankly. And as well, look forward to your thoughts as to how we could streamline and make it a little bit more easier, if you will, but making sure that we still have quality in the process, so that we can get people back to work.
Absolutely.
Thank you, Mr. Perez. I also want to acknowledge Assemblymember Perez's leadership in the Jobs and Economic Development as chair of that committee, and his efforts to try to maximize the use of federal stimulus and job creation in a time of high unemployment. So thank you for your leadership there, Mr. Perez. I want to thank panel members. We are going to move to our next panel. I do look forward to us maintaining a close connection with your offices and agencies, and for you to feel free and open license to feed us any ideas that we can partner on the legislative front to help you in fulfilling your missions. And we look forward to taking these challenging times and turning them into healthier times for the state of California. Thank you very much.
Thank you.
And friends, now we're going to, we have a number of people who will be speaking on different aspects of healthcare workforce development. I think I'm going to invite the first three listed on the agenda to come, and we'll hear from that group, and then followed by 4 others, just in terms of space up here. So I'd invite Jennifer Mitchell, Policy Director of the California Workforce Association, Steve Barrow, Policy Director, California Rural Health Association, and Annette Smith-Doring, California Hospital Association. And so we'll hear from those three, and then followed by the next group of four. And I expect, I don't want to cut anybody short, but I think this will be a little shorter testimony. We're interested in the highlights of what your organizations are doing, and we'll see if we have further questions up here. But welcome all, thank you, and I'll just take it in the order. Jennifer Mitchell, California Workforce Association.
Thank you.
Welcome.
Thank you very much, Mr. Chairman and members. I am with the California Workforce Association and here representing the 49 workforce investment boards throughout the state. And there will be a connection, you'll notice, to Ms. Halsey's testimony, since she represents a state board which sets the policy for the local boards. And so I had a number of examples, specific examples from different areas throughout the state. I think I may ditch those and just give you some what I think are promising practices, because they seem to be pretty consistent, and tell you a little bit about what our organization and members are doing, and then give you kind of what I think are a good set of recommendations, considering we don't have enough funding. We do have many strong partnerships that have been formed at the local and regional levels. Some folks have done this organically on their own. Some have done this with funding through the State Workforce Investment Board. We also have received a grant from the California Endowment specifically to increase diversity in the healthcare workforce, and to help areas develop strategic plans around how to do that. And at the end of that grant period, we will be putting together a cookbook or a template for how other areas can replicate that planning process and, in fact, increase the diversity in their own healthcare workforces. And I should say we're more focused on, you know, the allied healthcare, nursing, all the different technicians, and not so much the physicians and PAs, the higher levels. I also think that as part of diversity in the workforce, that includes cultural competencies. And I actually heard an example, and I hope I don't get it wrong, but it made me cry at the time, so I might not get it right. One of our board members was meeting with folks at a hospital involved in a partnership and talking about these issues. And at that time, heard wailing coming from a room, and a young child had died. And the father had refused to have that child removed from the room. They wanted to come in, remove the child from the room. The father was monolingual. They brought in a Spanish-speaking young nurse who pulled the father aside and said, "Do you want your child blessed?" And he said yes. And they brought a priest in, and the father held the child in his arms while the priest blessed him. And, you know, didn't bring his kid back, but it made the family feel much more comfortable. It's like these kinds of things that we don't think about when we're talking about policy really do need to be infused into planning and how we're thinking about taking care of your constituents. I'm not going to get into, again, specific areas. We have a lot of areas that are doing great things. In addition to the cultural competency and diversity planning, we know that the aging workforce is a real problem. We also know that although we have a shortage of nurses and other allied health workers, that the hospitals don't necessarily have the money to hire them. There are training issues. Nurses who are hired by hospitals usually need to have been nurses for a year, and they need to have mentors, and that's very expensive. If you're bringing in somebody and you're assigning a mentor to them, that takes away, you know, money from the hospital at a time when people are losing their health coverage and hospitals have less money. So in one of our areas, what they're doing is they have a program where instead of having nurses go in for a year and having mentors specifically, what they do is they have mentors for a week at a time. They're on the floor of the hospital for a week. They're pulled out and then have classroom training for 2 weeks at a time. And then that's all contextualized. And then it's a 9-month program instead of a year. So this saves the hospitals over 2/3 cost of what it would normally cost to train and hire new nurses. So I'd also like to reiterate the broad partnerships that are occurring. I mean, we have collaborations with the community colleges, universities, associations, the hospitals, community clinics, high schools, public health agencies, health insurers. Community-based organizations are huge. A lot of the folks who are referred to bridge programs or programs where you can go in and become a CNA to LVN to RN, a lot of those folks are actually referred by faith-based organizations, by their churches. So I would keep that in mind and get the faith-based organizations involved in planning. Sorry, I'm skipping through because I had way too much testimony. Again, over and over again, we're hearing that hospitals cannot afford to train the nurses, but they need them. We also know that nurses who we thought were going to retire didn't. We know that they're going to be retiring, and we need to be preparing them. With the new the healthcare coming down, I think we need to be looking at other funding sources. A lot of our folks have philanthropic partners, and I just wanted to share a list of those from one of the partnerships that includes the James Irvine Foundation, the William and Flora Hewlett Foundation, the Walter S. Johnson Foundation. So, you know, maybe somebody might want to put in a call to Bill Gates and see what he's doing. We're also, our folks are very involved in crossing over, you know, between the workforce investment boards and doing regional planning that works. So although there are 49 boards, I know that Barbara mentioned, you know, different areas are working together. They're cobbling together funding and doing some really innovative things. And the most important things I think that we're hearing is that in terms of recommendations is curricula needs to be consistent. There needs to be more funding for the community colleges specifically. If you could drop the FTE cap, that would be really nice, or make that higher. That would be helpful for them, I'm sure. But the FTE, the full-time equivalent cap, it's a funding for the community colleges. I mean, I think it's also helpful that under the Recovery Act, our members had the ability to contract directly with institutions of higher education without having to go through an eligible training provider list or an RFP process. So, but that's something we're working, you know, at the federal level to keep in place. So the primary recommendation is that there be regional planning with all partners, and that doesn't mean just the colleges and the workforce investment boards and the hospitals and the clinics. It means faith and community-based organizations. It means philanthropic organizations. And I would say, you know, bring the students into the mix as well. And that there has been seed money for that. Hopefully we'll see more of that, and hopefully we can get more business and philanthropic involvement in that. And those seem to be the primary recommendations, and continue brokering those partnerships.
Well, thank you, Ms. Mitchell. And I think we will move to our next panel members and reserve questions till later. The story you shared about the family who lost a child, I think that graphic, as tragic as it is, says volumes about one of the components of workforce development and the essential need that in underserved communities there be culturally appropriate training, language capacity, etc. has to be part of this formula for it to be successful. So thank you for sharing that.
Absolutely. I also wanted to say one more thing. We are a member of the California EDGE campaign, which is a diverse group of folks involved in job training. And so we have that state level partnership happening along with the task force and other things mentioned, and those should all be coordinated and aligned as well.
Thank you. And now we will move to Mr. Barrow from the California Rural Health Association following our agenda order here. Thank you.
Hi. My name is Steve Barrow. I'm the Policy Director for the California State Rural Health Association. This is an association of the hospitals, rural hospitals located. There's the different kinds of hospitals, different kinds of clinics in the rural areas, individual providers, dentists, a lot of other individual members, advocates. It was created because there was a need to have a place, and I call it kind of the United Nations of rural health. It's where everybody can work together because, as you know, there's difference of opinions and different perspectives. So that's what the organization is. Its job is to communicate, convene, share best practices, do research, and support existing organizations that are functioning out there, all towards increasing the quality and the access of health care. Okay. Oops, did I just blow it, Pedro? Got it. Okay. Obviously, the importance of focusing on rural is 85% of our state is rural. 1 in 60 Americans live in rural California. We have 5 million people that live there, and so they're dependent on the healthcare system. But obviously, many of the other 35 million people in California, they travel, they recreate, they have jobs there, they have family there, and so when they're there, they depend on, they expect a high quality healthcare and a lot of the staff that goes with that. Just a couple of the facts here is 11% of the workforce in the rural areas are in the healthcare sector, and that doesn't account for the other parts of the economy at the rural areas, you know, that sell them paper towels, clean the floors, build the buildings. There's a lot of other economic in the pyramid of healthcare out there. Agriculture is 9% of our workforce in the rural areas, and the healthcare is 11%. It is a big economic factor in many of the communities where the healthcare exists. It also it's well known, and you and the legislators here will know that the disparities in the workforce in the rural areas is much more pronounced than it is in urban areas. But even in urban areas, it's just not where it needs to be, especially for underserved populations. We have, underneath the association, there's several different things that we try to do to support and work on the workforce arena. One of the things that we have is we have our own task force. It's called the Rural Workforce Advisory Committee. And two of the big projects they have going on right now, one is we've been working with the Rural Caucus, and Assemblymember Monning has been coming to those hearings. We've been holding hearings to help elevate the information around rural health and health information technology, and just generally to legislators that have to make policy decisions and come from there, and to help the Rural Caucus speak with a unified voice around this, because there's few of you that there is of your urban peers. We have the workforce hearing that we're working on right now with the Rural Caucus and with Assemblymember Conway, who is the chair. But we're also working and having conversations with Galgiani's staff right now in the Agricultural Committee to do a joint rural workforce issue, looking at the economy generally and how rural workforce can help in that regard. The other thing we do is we do a lot of communication with the rural community about what are best practices, what are programs out there. We try to do linkages to existing things. There's a lot of, as many of the people have been testifying today, a lot of good things in place, and we try to help increase the communication and knowledge. And as you all know, everybody's busy in their real life, especially people running hospitals and clinics. So by trying to provide short communications to them, we can help elevate where they have attention span during the day after they got done with their 50 patients to be able to pay attention to what else is going on and to lend their voice. And so that communication through the association is very important. There are some recommendations that have been coming out of our come out of our task force, our advisory committee, and I just wanted to touch on just a couple of those. To shorten the time here, as you heard today, there are many good programs in place, both federally funded and state funded, and some local programs. I'm not going to name them all and go through each one of them, but one of the important things the legislature can do is to pay attention to those and support them and make sure they have adequate funding. One of the things we've done a lousy job in California is to pay for programs that we know that work and bring them up to the capacity we know they need to have to serve a state this diverse and this large. So paying attention to those programs, paying attention to programs and supporting programs that bring together training programs with the healthcare providers themselves. A good example is that UC Davis Pediatric Residency Training Program. When Dr. Pan came in from the East Coast and started running that program a number of years ago, one of the things he did is require residents to go out and work in the rural clinics, safety net clinics, so that they get firsthand knowledge about what it's like to work in a community and in those clinics. But that's a good example of things that we need to continue to do is while you're going through training, go out and work in the settings. Also, we need to make sure that our broadband system is thoroughly statewide, for not only just for the health information technology and the adoption of the meaningful use for health information exchange and medical records going from paper to electronic, but I was up in the Padawat Clinic just about a week ago up on the North Coast, and the gentleman up there, Harold Horn, who runs their IT department, was showing me how they use that to bring together people to do trainings, educational programs, not just telehealth and telemedicine. So those systems that they set up are important for the healthcare they provide, but they're also important for making sure that distance learning and bringing peers together to do their further education is important. Another issue around retention and recruitment is that we need to make sure that federally and statewide, any program dealing with loan repayment, scholarship, and training programs that provide incentives for practitioners, especially when they're first coming out of school, that they go and they work in underserved areas. And in the rural areas is where the dire need is, but urban areas still have underserved, and we need people working there. So you incentivize them, and sometimes you just require that they work there. A lot of times you'll find a significant number of them will stay. They find that they like it. The things that they thought they would never practice in that kind of an area go away once they're there and they meet people. In the technology area, it's already been talked about. All the rural providers and all providers are going to have to go to meaningful use on health information technology by around 2014, 2015. That means that there's going to be an incredible new need for IT staff. Not just IT staff, but also medical staff that have to be trained and retrained in how to use a computer, how to use telehealth, telemedicine, because they're going to have to be there. If they don't go to adoption, they're going to get penalized in the reimbursement rates, and rural clinics, rural hospitals are, most of the time marginally running as far as their cash flow. So if they don't get to the electronic system in place, then they're going to have a problem with just their cash flow. So, but that's going to drive up the workforce needs and the thinking and all the support that's going into the current planning around how do we build our IT staff. I can tell you from being out in various places in the last couple of weeks, that's a big concern. They're nervous that they're not going to be able to have that. Shasta County Community Clinic went from having 12 people working in their chart room to having 10 people working in their IT staff, full FTEs, in just a couple years. So that was a transition. So we got to think about, okay, how do we get those kind of skilled folks out there too? It's good work too, and it's green work. The other thing is that the green economy, these going from paper to electronic is greening our medical system. Besides the most important thing, it increases the quality and the access, but that's an important thing to pay attention to. There are a couple other things that, from the association's viewpoint, we think we should be looking at. We haven't vetted these through our advisory committee yet, but I wanted to mention some of them because they're going to be important. We're having a meeting on Friday where we're going to start working and talking about these. One is the association is in a position where it could maybe help support the development of more and more scholarship programs that are run at the local level to make sure that people that are unemployed or people that want to go into the healthcare field, auxiliary or allied health field especially, that they get the support they need. Child care payments and, when you're going to school and all kinds of other things are really expensive. And so having scholarship programs in place are going to be desperately needed. We also need to find a way from the association to help support the growing out of education, training, and licensing programs at the local level to make sure they have the infrastructure. And there's a lot of other things going on, and we can help convene some of that. There is on the landscape, you might have heard or might not know that the CDA has finally decided that they need para-dentistry level of employment in place, and so they're working through a Pew grant with a lot of other folks to look at how do we develop another layer of dentistry to make sure that in underserved areas we have people that can do more than just hygienist work, but not quite dental work, and that's going to be coming up on the landscape. I can tell you from my personal experience, when I started out as a young man, that I no longer am, I started out in emergency medicine, and through the EMT program. My idea was I had brothers who were in medical school. I couldn't afford it because parents dumped all the money into them. And I can tell you what I thought about that. But anyway, I couldn't afford it. So I was going to go to medical school through a new pilot program called the EMT 1 through 10. And it's just a good example. That program didn't last very long, and it ended. But I started and I got up to EMT 3, and I was practicing in the field, and my intention was to go all the way up to emergency room physician or PA or whatever it was going to end at. Well, that ended. But that harkens me back to we need to be creative. We need to think about how do you help people, especially when they're young, come into the field and move through the field and move up in the field, because as we all know, working as an LVN is not going to support your kids when they get to college age a lot of times. A lot of people, and bless them, love it. They stay there. LVNs and RNs and other auxiliary healthcare are the backbone of our healthcare system, besides the physicians and the higher level professionals. But we need to help people move through. We need to get creative about how we help them provide opportunities to move through. It's not just become an RN, that's it for life. Don't just become, an LVN, become an LVN for life, or an EMT or a paramedic. You can move up and out. So there are 10 really quick things I just wanted to mention that legislators could do to help. One is providing a unified, comprehensive vision. One of the things we don't have very much in this state anymore is because of term limits and because of the churning over of our legislative leadership sometimes, is that we need that unified, comprehensive vision of where we're going and how to get there. When you think back at the Pat Brown and Jesse Unruh and Ronald Reagan years when they were in charge, there was a lot of people who had been around for a long time, and so they had these uniform visions and they moved on them. And that's where the roads came from, the highway system that you see. So we need that. Also, avoid passing legislation that creates new regulations and guidelines unless they're part of the game. And another thing that we have a third of the legislature's turnover. It would be really important to make sure that new legislators and new staffers get oriented into what's going on already on the landscape and in this field, and how they can be a part of that. So orientation of the new legislators is really important. That legislators become increasingly knowledgeable about the education system programs that are in place and all the other programs that are in place, so they know what to do. Support coordination between frontline educational programs and training programs so that they're in touch. Utilize foreign medical students and foreign folks as much as we can. J-1 visa is a really good example of how we bring some people into especially underserved areas because they're required to work there. We get a lot of really good docs in the rural area through the J-1 visa program. Make sure that the governors align with the legislature so that it's not legislative working really hard and then the governor stepping in. Enough said. One of the things that would really help us in the rural area is helping the rural located hospitals and rural located clinics get to a point where they can solve the problem of physician hiring issues between those settings, because the problem is that there's not enough physicians. But we need that solved so that there's uniformity of effort on a lot of other areas rather than focusing on that. That is a real important area that gets resolved. Reimbursement rates need to be looked at in an underserved area. We need to make sure that we sustain higher levels of reimbursement to keep people there and able to be there. And the last thing is that I'd like to say is this, listen to the front line. It's easy for you, Assemblyman Mine, because you have the front line at home. But, you listen to the front line. Site visits, which I'm assuming you do in your districts, are really important to understanding and hearing what are the good ideas really working, or are there barriers that we're building up and we're not hearing from the front line. Thank you for your time.
Thank you, Mr. Barrow. It was very helpful, very comprehensive. I liked your opening description as being a United Nations of workforce healthcare communities. So we look forward to our continued work with you. And now we'll turn to Ms. Smith-Doring with the California Hospital Association. Thank you for your patience and for joining us today.
Oh, thank you. It's my pleasure to be here. I'm Annette Smith-Doring. I'm the Workforce Development Manager for Sutter Health in the Sacramento Sierra region. Today, though, I'm representing the California Hospital Association and their Healthcare Workforce Coalition. But before I start those remarks, I do want to make sure we don't forget. We've touched on a little bit about some of the other shortage areas related to nursing. And we've done a lot of work in this state with tremendous success and outcomes related to nursing over the last 5 years or so. And I do want to make sure that we don't miss the ball and take our eye off of it, and that those efforts continue. There's also opportunities to replicate those efforts in other allied health areas. There is a huge shortage of physicians in this state. We train quite a few of them, but most of them don't stay here to practice. And so we need to make some efforts around ensuring that we are retaining our physician and medical students within the state. So about 2 years ago, the Hospital Association created the Healthcare Workforce Coalition, whose mission is to lead a statewide coordinated effort to develop and implement strategic solutions to address a shortage of specific non-nursing allied health professionals. They are part of a very important part of the multidisciplinary healthcare team, and in some areas, if you don't have certain qualified staff available, you literally have to shut down your emergency department. It could be something as simple as an ultrasound technologist is not available, and you can no longer take patients into your ED. So there's some significant community health issues related to the shortages. Some of the members of the coalition are not only the hospitals and health systems, but there's also other stakeholders like our higher education representatives at the UC and the CSU system, the community colleges, OSHPED, Connecting the Dots Initiative, as well as CPCA, among others. In order to establish our priority areas, we conducted a survey in 2007 in partnership with the Center for Healthcare at UCSF. I just lost the title of it. What was that? Center for Health Professions. Thank you. From the gallery. We've recently completed a new survey, and those results will be available later in July. There's many barriers to addressing the workforce shortages. A lot of them are linked to the limited capacity of our California public institutions of higher ed to develop these professionals. And within California, most of the allied health professionals come out of the community college system. And the capacity issues, they're chronic due to persistent budget issues, challenges that you've heard about earlier. But also the limited capacity is also linked to how the health sciences are funded. The health science courses are costly due to the required faculty-student ratios, and those ratios are there because healthcare education is so very different. It's very different teaching someone how to be a nurse, how to be an imaging tech, as it is to teaching them how to do math. You can teach 400 students how to do math all at once, but when it comes down to allied health and actually touching patients on a regular basis, you're talking 10, 11 students to one instructor. The problem, though, is that they're currently funded at the same level as those math courses that can take 400 students. So there's an inherent disparity, and they're very costly, and there are some colleges in the state that are actually thinking about eliminating their healthcare programs because of their budget situation, which would only exacerbate our existing problems. The state's public institutions of higher education are at the heart of our developing our health professionals going forward. Yet our master plan for higher education is over 50 years old. If we are going to be effective in addressing the healthcare workforce shortages, the plan must reflect current educational, economical, and technological realities. Let's see, is there anything else I can share with you that my colleagues have not already? There's another side to our remarks from the Hospital Association that you will hear from my colleague, Janice Bueller, in just a moment.
Well, thank you very much, and for wearing both the hats of your experience with Sutter and CHA. We appreciate your presence. Any questions, Mr. Nastandi? I just want to thank you all for working with us, and see this as the beginning of an ongoing conversation. Thank you very much.
Thank you.
For joining us today. And we'll now invite the next four on this panel: Janice Bueller, Director of Recruitment and Workforce Planning, Cedars-Sinai Health System; from the California Primary Care Association, President, CEO, Carmela Castellano-Garcia; from University of California Health Institutions, Angela Gilliard, Legislative Director, Health Services and Sciences, UC Office of the President; and Community College Economic and Workforce Development, Stephanie Leach, Assistant Vice Chancellor. So welcome all. Thank you for your patience this morning, and we're looking forward to your inputs. If it's okay, I'll just proceed in this agenda order with Ms. Bueller. Welcome.
Okay, thank you. I'd like to expand upon my colleague, Ms. Smith-Doring's remarks about education. There is a significant need to expand and explore alternative models of education delivery for health education. Many of the current models are centered around the traditional student, and they're not as effective in serving the non-traditional student. And that person I'm talking about is someone who is fully employed and may have family obligations, including child care and elder care. The use of technology in delivering distance learning can not only expand access to prerequisites, but it also has the added advantage of expanding access to those who are located in rural communities. The use of technology can also expand clinical training, which normally has to take place in a clinical setting. You can utilize technology for clinical simulation. You can utilize technology for clinical mentoring through virtual access programs. Notably, and on the subject of technology, I'd like to add that in implementing an electronic health record, technology does not diminish the need for additional staffing in a healthcare setting. Healthcare is people taking care of people, and with the implementation of an electronic health record, we've seen actually an increase and also a significant change in the skill set required by our workers. Not only do they need to be clinically competent professionals, but they also need to be technology savvy in order to manage the job requirements that are upon us with an electronic health record. Education must be responsive to the industry needs for a technology-savvy and also culturally competent workforce. And by expanding access, many of the workers who fall into the non-traditional worker are of a diverse population who cannot afford the time or are not in a position to go back to school full-time, who need a full-time income and also want to pursue their opportunities for career advancement on a part-time basis. The need to train the healthcare workforce of tomorrow right now has never been greater, even though it has been stated that there has been a slight shift with the current economic climate. There is a looming crisis in the number of retirements of healthcare workers in all different clinical professions, ranging from nursing, physicians, to clinical lab scientists. That's an area that's currently acute. Something that I'd like to speak to is the healthcare industry is currently and has historically done their part in creating and investing in workforce initiatives and partnerships, whether it be in physician education, nursing education, or allied health education. I can cite an example of that at Cedars-Sinai. The question came up about K through 12 education and the healthcare academy. Cedars-Sinai sponsors a healthcare academy, has for 15 years. We've had over 1,000 graduates. It addresses students who are juniors and seniors in high school, and the annual investment in this it's a private academy. We are affiliated with the LA Unified School District Regional Occupational Program. We've graduated over 1,000 graduates over a 15-year period. Many of these individuals have gone on to pursue, in fact, the majority, 70%, have gone on to pursue healthcare occupations ranging from being a physician to a pharmacist to nursing to information technology and healthcare. And all of them come from economically disadvantaged, and the graduate survey, the majority represent African American and Hispanic students, and that is an approximate $500,000 investment on the part of a private employer in terms of this type of model. This is an unprecedented opportunity for the federal resources to be obtained for the state of California, and it was mentioned that we already are at an uneven playing field as we move forward with healthcare reform. The opportunity represents for California to move forward with by coordination and collaboration between state agencies, the legislature, the educational system, and private employers are among all the stakeholders who could take advantage and certainly build the healthcare workforce in this state. California Hospitals, as a private employer and on behalf of California Hospitals, we look forward to the opportunity to participate as we move forward.
Great. Well, thank you very much. Appreciate your testimony and being with us today, and I think we'll hold questions till we get through our panel. I want to next welcome Ms. Castellano Garcia, President and CEO of the California Primary Care Association. Welcome.
Thank you. Good morning. We really appreciate this opportunity to speak on behalf of the 800 community clinics and health centers in the state of California on this critical issue. And as healthcare reform unfolds, California can certainly expect a rapid expansion of newly insured patients and significant increase in the demand for healthcare services. This will especially be the case, we believe, in medically underserved areas of the state where uninsured patients have likely been foregoing access to healthcare and therefore will be in need of a variety of basic healthcare services and be present with more complex conditions that will need to be addressed. And all this is going to take place at a time when the existing shortage of providers is great, as we all know. President Obama and Congress have shown great vision by investing significant resources in healthcare workforce and really have called special attention to the need to focus on an investment in primary care and primary care providers, and we certainly applaud these initiatives. The primary care investment is very apparent in their targeting of community health centers for expansion in healthcare reform, and it bears mentioning that community health centers will be receiving a $9.5 billion investment over the next 5 years with an expectation that they will be serving 20 million new patients nationwide, with anywhere from 3 to 4 million new patients in the state of California alone. Now, keep in mind, this is in addition to the existing clinic patients we're already seeing, which is numbers over 4 million currently, and really on top of the flood of a new flood of newly unemployed and therefore uninsured patients that are at our clinics right now as a result of the distressed economy. Now, there will be significant resources for clinics to expand their infrastructure, as I just mentioned. It's going to be very difficult for us to be able to do so, however, without having an adequate number of primary care and other allied health professionals to meet this need. I also just do want to mention that in terms of the new funding to the state of California for community clinics, only half the clinics in the state will be eligible for those dollars, as it is only the federally qualified health centers who receive the federal funding, and there will remain 400 community clinics that will not have access to these federal funds unless they become federally qualified health centers. So it bears mentioning that not all clinics in the state will be receiving the expansion dollars. Moving on to the workforce piece, however, there are many provisions in healthcare reform that will be incredibly beneficial to community clinics, and I think they bear mentioning, and I just want to review some of them for you and what the clinics are doing to pay attention and make sure these are implemented in California. One very important program is the National Health Services Corps program, which is a scholarship and loan repayment program that targets health professional shortage areas, so those parts of the state where there is a shortage of healthcare providers, and it provides physicians, dental, mental health providers to meet the need for primary care. And what these providers do is they commit to a 2 to 4 year commitment to serve in this community as a result of receiving the loan repayment. We are so pleased that this program is being expanded with a $1.5 billion appropriation. And the reason why this is important, keep in mind that according to the National Service Corps, nearly 80% of those providers who go through this program actually stay in underserved areas after fulfilling the National Health Service Corps commitment. So that's really critical, and more than half actually make a career out of serving underserved individuals. So I think that's really important. There's currently 3,800 clinicians in the country serving 4 million people, but there's currently more than 9,000 job vacancies for National Health Service Corps providers. So clearly we need to fill these vacancies, and outreach will be critical. And it bears noting that more than half of the core providers in the country are actually working at community health centers. So clinics in California, we expect to be very big beneficiaries of these expanded dollars. So as I mentioned, it's $1.5 billion in new dedicated funding over 5 years for this program, and we think that that's critically important. And there's some very important improvements to the program, such as they're going to increase the award amounts, and they're going to be allowing for part-time providers to be core providers. And we think that's going to be really important for our employees in community health centers. Keep in mind that community clinics are located in health plan shortage areas, so that is why there's going to be a continued need for core providers in these areas. And the way that the state can assist is really to help with the outreach and education that we need to do for the potential providers in the educational institutions, as well as to make sure that the job vacancies are well known. And just on a related note, in terms of a regulatory issue, part of healthcare reform included the federal government forming a committee to actually revisit the rules governing health plan shortage areas. They've tried this in the past, and due to tremendous uproar from the advocacy community, they have withdrawn proposed regulations in the past. Well, it's going to happen this time. It is critical that California, and we'll be working with OSHPD, would be vigilant about this process and assure that any new regulations do not disadvantage California. And we are actually seeking to have a slot on the national committee being formed to oversee this. But I just wanted to bring you attention. This will be very important for California to monitor and have a very active voice in. Additional important programs, there are other loan and scholarship repayment programs that will be very important to community health centers that we see in healthcare reform, including investments in nursing student programs, training in family medicine, training in general pediatric and public health dentistry, and the Allied Health Loan Forgiveness Program, very important as community clinics rely very heavily on allied health professionals in the team-based model of care. So we really encourage the state to continue to communicate with the federal government about the need to actually appropriate the funds for these particular programs, because until those funds are appropriated, they will not be implemented. And those are going to be very critical for California and our health centers. Another important provision I want to make you aware of, very specific to community clinics, is the concept of the teaching health centers. And what this is going to do is support new or expanded primary care residency programs at teaching health centers, which includes and specifically designates community health centers as sites for these programs. This is going to be really important, and there are additional funding allocated or potential for allocation of funds to expand these programs. And the reason why they're important is that studies show that when residents are trained at community clinics, they are more likely to return there to practice their medicine. And certainly with the shortage that we have, this will be an important opportunity for recruitment. And teaching health centers will also allow us to attract dental professionals, as dental residencies are going to be part of this program. Another reason why the teaching health center concept is so important to us is that it really will help reduce some of the traditional barriers that we currently experience in trying to implement residency programs. The way the general medical education funding currently works, it goes directly to the hospitals to cover the cost of these programs. And so the clinics are pitted against the hospitals in terms of the appropriate reimbursement for these training programs. What the new teaching health center concept will do will allow the funding to go directly to the community clinics to oversee, implement, and have the curriculum for these programs while keeping the current GME program intact. So we will have two complementary programs that we think will be excellent. So we're very supportive of this, and we hope the state will urge the federal government to do the appropriation so we can kick these programs off, and we think California will be very competitive for these dollars as well. It's worth mentioning that the area health education centers are also authorized to establish community-based training and education grants. AHECs are an important part of the infrastructure we have in the state to develop workforce at the local level, and they're important to us because they really help create linkages between the health profession schools, health professional students, and entities such as community clinics and health centers. In fact, currently 11 of the 14 existing AHECs in the state are housed at either community clinics or regional clinic associations. So we were very pleased to see this recognized in healthcare reform. A few other provisions worth mentioning. There will be support for nurse-managed clinics, which is an important opportunity for nurse practitioners in family residence training. There's also going to be grants to promote the community health workforce, and there is extensive use of community health workers in community clinics, and including promotoras, and we think this could be an important funding opportunity for these programs, which historically have solely been foundation and grant funded and difficult to sustain. So in conclusion, I do want to take this opportunity to commend Secretary Belcher and others in the administration for taking a leadership role in beginning to implement a coordinated statewide approach to trying to get the workforce dollars available in healthcare reform. They convened a meeting in the last several weeks where they tried to bring together some of the key leaders and partners to really begin to look at this. And we think it's really important because there's a need for a coordinated and inclusive effort in workforce. More specifically, I do want to highlight that it's been through efforts such as the California Workforce Alliance, which is working to develop an essential statewide strategy around workforce, including issues of the safety net, but not solely the safety net, healthcare workforce more broadly. And we really encourage the state of California to support these efforts, such as the California Workforce Alliance, looking at a broader strategy in the workforce arena. And lastly, a very important point I want to make, because these federal health reform grants are designated to state agencies, it will be the state of California, the Department of Public Health, and other departments that will actually be applying for these grants. And I have to say, in our experience in attempting to partner with the Department of Public Health on workforce grants specifically, we have found that there are some serious administrative barriers that have gotten in the way for the ability of the state to draw down federal dollars in workforce. And so we believe that it's going to be very important for the state to undertake a couple of efforts to remove these administrative barriers. And these include specifically, there's a need for a feasible process that will allow the state to pull together competitive federal grant proposals in a timely manner. There needs to be a clear and workable process to subcontract with private nonprofit entities, such as the Primary Care Association and many others who have the ability to do the work at the ground level, but don't they have the ability to apply for the grants because the way the feds run the dollars through the state. So we need to make sure that there's a streamlined process for that. There needs to be a better practical streamlined process for actually executing contracts, which can take months on end to negotiate budgets and ultimately get funding, puts nonprofits in a difficult position. And finally, we need to streamline subcontractor payments to the nonprofit sector once they execute a contract with the state. There shouldn't be excessive delays in being able to receive those payments. I want you to know that we are working very closely with the Department of Public Health. Dr. Horton is engaged in this discussion around what we need to do to remove the administrative barriers. But I want to bring your attention that we think it's going to be very important that this be done in order to ensure that we can draw down the federal dollars. Thank you.
Thank you very much, Ms. Castellano-Garcia. Very informative. I do want to move forward in the panel. I just want to ask one question on the loan repayment program earmarked for $1.5 billion. Does that have geographic distribution, or is it just based on qualified medical school graduates who seek to apply for it? You indicated a $1.5 billion federal commitment to the loan repayment for primary care doctors going into underserved areas. My question is that is a certain amount of that allocated for underserved areas in California, or is it just linked to eligible applicants wherever they might go to serve?
Well, the areas where they go do have to be health plan shortage area designation. So that kind of defines the geography of where the the individuals are allocated.
Right, but of that 1.5 billion, in other words, there's not a certain percentage of that that's allocated for California for doctors who would come to California.
And I'm not aware that there is an allocation for California in the National Health Service Corps funding.
Great. Okay, thank you. I'm sure there'll be some other questions. I want to welcome Dr. Hernandez back on the dais with us, and we'll move forward to Angela Gilliard, Legislative Director, Health Services and Sciences, UC Office of the President. Welcome.
Well, and thank you for having us here today. I don't know if it's afternoon yet, but my prepared speech says good morning, and maybe it's good morning and approaching afternoon, members of the committee. UC Health includes 16 professional schools and 5 academic medical centers, and UC Health is actively engaged in identifying funding opportunities made available through health reform. Health reform provisions provides funding for health professional education, financial assistance for health professional students, hospitals and clinics, and provide graduate medical education and more. I can provide the committee with examples of with medicine, School of Medicine, School of Nursing, public health and multidisciplined activities as examples of UC's efforts to pursue the funding that may be available. With regard to medicine, UC Irvine School of Medicine has applied for a HRSA grant under the Enhanced Group Medical Visit Act as a model of culturally effective, relationship-centered, patient-centered, team-building, team-based care project, which introduces a new paradigm of care addressing needs of underserved, culturally diverse patients with chronic conditions, and develops new clinical and pedagogical skills. You know, one of the things that health reform did do is it has percolated. I think it is required that ideas have percolated at the UC and in the health community about how to actually serve people in various communities, and I think that's what this committee is here to address. And UC Irvine has a program that they are putting together that basically proposes to build capacity by working with their 2 federally qualified health centers and a student-run free clinic by teaching medical and nursing students, family nurse practitioners, to work together in a team approach. Because I do think what part of the conversations that we're having is the current model of providing care has to be expanded. I think we do have to go to a team approach because we do not have enough physicians of any type really to meet the demand. So we have to expand the way care is provided. UC is beginning to look at these different models, and UC Irvine is actually establishing a model that will do that. I think some of the other campuses are following as well, but they're pursuing funding on that front. With regard to UC Irvine, they're applying for a grant to develop teaching health center when the regulations are fully developed. So we are planning to be in the pipeline for those funds. With regard to nursing, UCLA School of Nursing will be competing for a nurse-run community clinic grant to enhance the Skid Row Clinic. They will also be competing for a wellness center grant, an advanced nursing education expansion, and grant for programs that prevent vulnerable nurse practitioner students from dropping out of the nurse practitioner program, along with grants for student scholarships. With regard to University of California, San Francisco, the School of Nursing at UCSF just learned that their proposal for a wellness center will be funded at the rate of I think it's about $1.5 million by HRSA, and they plan future submissions to support the center's primary care services. UCSF and the San Francisco Glide Health Clinic, along with I think it's Catholic Healthcare West, offer health care to homeless and opportunities for nursing students to gain clinical experiences. Also, the University of California has a system-wide approach. In June, UC applied for HRSA grants for the Health Careers Opportunity Program, which is a program designated to build diversity in the health fields by providing students from disadvantaged backgrounds an opportunity to develop the skills needed to successfully compete, enter, and graduate from health professional schools. The goal of the UC proposal is to create a more coordinated and effective pipeline into health professional schools for disadvantaged students by expanding the infrastructure and shared resources of the highly successful UC post-baccalaureate consortium to develop a collaborative partnership of K-12 undergraduate, post-bac, and professional school retention. So, again, we are looking at greater coordination and greater retention of our students and reaching out into the communities. With regard to public health, UC Berkeley, the School of Public Health, has submitted 2 proposals for HRSA funding. The first is a proposal with UC Davis, CSU Fresno, and University of Hawaii for a California Pacific Public Health Training Center. The focus is on providing training to increase the capacity and performance of public health and safety net workforce, expand collaborative projects to address health issues of underserved populations, and increase student field placement in underserved communities. Second is a proposal submitted by Stanford as a collaborative project between UC Berkeley School of Public Health, Stanford Medical School, and San Francisco State University for Bay Area Health Career Opportunity Program. The Bay Area program would support disadvantaged and underrepresented Bay Area undergraduate, community college, high school students to help pursue health careers in medicine, public health, physician assistant, and allied health careers. In addition, UC has provided names to OSHPD for recommendations for inclusion on the National Healthcare Workforce Commission, and UC will continue to actively pursue funding for existing programs and develop new programs that will allow us to participate in healthcare reform.
Well, thank you very much, Ms. Gilliard. I had the opportunity to meet a week or so ago with the new medical school dean at UC Riverside, which is transitioning, as you know, from a 2-year kind of pre-med program to a 4-year medical school. And my question to him was about recruitment of medical students. And he said he's more interested in the profile of a prospective medical student, in their history of community service, volunteerism, etc. He said, give me somebody who's committed to the community, who has community roots, and I can turn them into a doctor. And I thought that was just a great profile. But he said that, I said, so what's the challenge to doing that? And he said a lot of young people who are active in junior high, high school, and community involvement often pursue social sciences when they get into a college program. And the challenge is, how do we incentivize those students early on to pursue the sciences and to consider health care, whether it's becoming physicians or allied health care roles? How do we get young people who have that commitment to community to see healthcare professions? Is there anything in your recruitment that you're doing to try to identify or incentivize students to pursue the sciences?
I actually think I would even phrase the problem a little bit differently, because I do think there is interest. I think there are barriers that prevent students with interest in continuing. In fact, we were just talking about this before we came up, and I don't know the statistics offhand, but I think that a number of students from underserved communities identify an interest in medicine, in fact, and other health professions, but do not, and there's probably a number of reasons why they don't actually make it through. One reason they don't make it through is just misinformation, not understanding that they can have a career in medicine, even if they don't have a 4.5 or a 4.2 or a 4 point something. That is a real barrier, because people think, I can't do it. Or, there are lots of, and I talked with Dean Olds. We've had long conversations about this, and there has to be a paradigm shift about math and science. Period. And maybe I'm not talking for the University of California. Maybe I've departed a little, but
that's okay. We're going to attribute it to the University of California. It sounds good to me.
You know, I may be applying for a new job soon, but no, I think there's a real passion for people within the university to see that people succeed, and I don't think we understand the complete reasons why people don't get through. There's a number of theories, but I do think that there is interest, and I think at the whether it's in the elementary school level, the high school level, and even in the college level, there are barriers in place to keep kids who are interested out of the sciences. And that's a conversation and maybe even a separate hearing. So I do think, and what Dean Olds did identify is that the students who do go to UC Riverside, they're entering statistics may not look exactly like the entering statistics in some of the other medical schools, but they are extremely successful and are retained. So I do think there's a larger conversation to be had, not just UC, but with medical education and with education around the sciences. The same thing is true, and I have friends who went through nursing programs, not at UC, but went through nursing programs, had a really tough time because retention and the whole attitude about how to retain.
And a lot of this goes back to early education, but I think that may be a good segue to community colleges. I'm going to thank you again, Ms. Gilliard, and there is a future conversation here, an ongoing conversation. We'll now welcome Stephanie Leach, Assistant Vice Chancellor, Community College Economic and Workforce Development. Welcome. I am going to have to excuse myself and turn back to Dr. Hernandez to assume the chair, and again to thank Dr. Hernandez for his leadership in convening this. I'll be able to listen to some of your testimony, but I'm going to apologize in advance because I have another commitment that I have to get to. Welcome.
Thank you. I would like to start by answering part of what you asked Angela. There are so many health pathway programs in California with so many motivated children who are having trouble with the math and sciences. I'll add that one. But there's a linkage that we need to work on to allow them access. I talked to a number of the educators yesterday at an event here in Sacramento, and the students cannot gain access because of the overcrowding we have right now in our community colleges and in our other schools. So we're looking at how we can give them, they used to be given priority access through dual enrollment programs while they were in the health academies or the pathway programs. And now with budget cuts, they haven't been able to give them that access. And so it's discouraging to those students, and they're going in different directions. So we're losing some talent that way, and we have to figure out how to address it. I want to tell you, first of all, what we have currently going on in the community college health and the nursing and allied health programs. At 102 campuses, we're offering 116 different allied health programs, including pre-health professions, for a total of 591 health-related programs outside of nursing. So that's quite a lot. That's quite a big footprint. And we're excited about that, and we want to link it to health reform, and I'll talk about that in a minute. In nursing, we have 45 campuses offering 78 LVN degrees and certificate programs, and 76 community colleges are offering 130 RN certificate and degree programs for nurses. We just released Governor Schwarzenegger's 5-year report, and we have expanded capacity by over 68% for enrollments. And the RN graduate rates are quite strong, and so we've met that goal. And some of the things we learned in that initiative we're expanding to the Allied Health Initiative. So I think that the public-private partnership model and commitments to the pathways in a more deliberate fashion will help us in allied health so that we can reach some of the goals we want. So the community colleges has been identifying key opportunities in the health reform bill, the workforce funding piece, by partnering with OSHPD and QIB as the health reform workforce work group, and partnering closely with everyone. Everyone is coming under that umbrella together so that no one's left out. We have some interesting new partners to add to the conversation: mental health, pediatric dentistry, people that we haven't necessarily been communicating with as much before. So we'll all be working together to work on the grant opportunities and also dissemination of coordinated statewide information so that we're all having the same conversation and working towards the same simple goals. We are at the community colleges also looking at using the health reform workforce changes, the health reform bill opportunities, to take some strategic approaches to some problems we have. We all know that there are a lot of RN graduates from the community college programs that have not been able to find jobs in the last 24 months. So there's some funding for nurse practitioners out of the federal bill, and we want to do a two-prong application, statewide application, that would have not only the generic nurse practitioner programs, but also take those RN grads and put them in a bridge program, a newly created bridge program, so that they would become nurse practitioners with a strong residency component. So I think that's how we have two solutions. We have more nurse practitioners sooner to take care of Carmela's clinics, and then we also have take them and use the skill set that they've already developed. You asked us to respond to the legislature's role in the health reform bill and California's efforts in education. I think maintaining an ongoing dialogue at your staff level with the healthcare workforce work group will be invaluable, so that you have a continuing dialogue and back and forth. I think it will be important for you to be aware of funding opportunities and priorities that have been identified, and stakeholder feedback in that process too. You could also work with us, the community colleges, in simplifying the pathway programs between academic partners. For instance, I mentioned at the beginning of my conversation with you the high school healthcare pathway programs not being able to gain access to the community college programs. That's a shame, and so we need to figure out what to do without penalizing the mainstream population and the other students that want to come through. We're interested in pursuing a core health professions curriculum that's recognized by all three systems. I think that there are a number of block courses that everybody needs regardless of the discipline they go into, whether it's short-term or long-term. And I think we need to get there. I think we need to go ahead and let that happen, and in the process educate the students as to the multiple choices and the new choices that are going to come out of the change in healthcare delivery. In addition, the special population of taking the military experience and training that they've received and translating that into academic credit and also bridge programs. We've done that with corpsmen, but there are many more that we can do that with. Finally, I'd like to point out that a priority of the Community College Chancellor's Office is cultural competency being laced in all of our current health profession programs. Instead of adding 3 more units on a cultural competency class, we'd like to lace it in, and we're working with the UC Center for Health Professions as to how to do that. They've done it with education and with industry, and we'd like to see that happen, and we haven't taken it in anywhere beyond an educational discussion, but we want that to be part of the health reform rollout, and it's not hard to do, so we're going to need to make sure that some funding gets put aside for that.
Thank you very much. I'd like to also thank Senator Romani for helping me work with this. I understand he will be leaving soon, so I will go ahead and take over the meeting at this time. The next subject we're going to be moving on to be item number C. Is there an opportunity now to create a health workforce master plan in California? I'd like to ask the California Health Workforce Alliance to come up, and that's Jeff Oxendine as well as Kevin Barnett to give their presentation.
Sure, I wondered if I could ask a couple questions.
Sure, by all means. I'm sorry. Did you want to ask some of the current? I'm sorry.
I might. This can be addressed by anyone here on the panel, but perhaps more so by Mrs. Carmela Castellano Garcia, and perhaps others as well. So I appreciate your points that all of you made, and I really believe in the concept of community health. What does that really mean? Well, in my opinion, the definition is not only dealing with issues of illnesses and disease and ameliorating those illnesses or diseases, but also taking a look at the social, economical, even political structures that exist within medically underserved areas. And so that means more than just going to the doctor because maybe one may need a vaccine or may have a headache or could be pre-diabetic. But also taking a look, for example, at the issue of water and perhaps arsenic in water and how that impacts our health and the quality of life. Or, for example, the trend of high dropout rates that we may have, and teenage pregnancy rates, quite frankly, that we may have in medically underserved areas in communities of color. There are many other issues, perhaps even students not having a safe pathway to walk to school, right? And that obviously is a public health concern. All that is to say is that I do definitely believe, as well as we're working on the issue of community health, on the issue of prevention and primary care. But I directly link that to promotoras and community health care workers. And there was discussion about that earlier. And so I just wanted to pick your brain on what is the future, in your opinion, of promotoras, of community health care workers. What is the potential funding? I know that you very quickly touched on that, but I'd like to hear maybe more expansion of that if you happen to have some of that information for me, as well as what's the potential for more workforce education and training as well for promotoras, and how can we also link the work of promotoras and the teaching health centers that are of the future. And so I have a bill as well, one last year, that recognized the efforts of promotoras in a resolution, and this year, number 2354, for those that are interested, in which is asking the Department of Public Health to do two things. Number one is to do an assessment, an inventory, if you will, of existing promotora programs throughout the state of California and identify their successes and challenges, but at the same time, identifying potential dollars that are going to be coming down the pike because of our healthcare reform. And so, obviously, I have a vested interest in this work and have worked quite alongside quite a bit with the California Endowment, quite frankly, as well, the Wellness Foundation, Irvine Foundation, and making sure that we could bring in dollars to local jurisdictions so that we can implement promotora models in our communities. But I would like to hear your points overall with relation to all that.
Well, thank you, Assemblyman Perez. I certainly appreciate you bringing up the issue of community health, because that is absolutely a priority consideration and something that community health centers have long incorporated into their approach to health care. And use of community health workers and individuals such as the promotora model, as I mentioned, have been very challenging in the community health center context because of the lack of reimbursement mechanisms for these very issues and for these very providers. And so, as I said, historically, they've been very much grant funded, and when the grant ends, sometimes a promotora has to end, or somehow they're trying to subsidize these programs. So I think a very important piece of healthcare reform is that it does call out the idea of the community health workforce. And what it specifically does is it authorizes the secretary to award grants to states, to public health departments, to clinics, hospitals, to federally qualified health centers and other nonprofits in order to promote positive health behaviors and outcomes in medically underserved areas, specifically through the use of community health workers. And I think that's very important recognition in federal law to say that community health workers, in fact, do serve this role in ultimately promoting positive healthy behaviors and positive health outcomes. So it actually encourages the establishment of an outcome-based payment system that will reward community health workers for connecting underserved populations with appropriate services. This is yet to be, further specified, but it will encourage it does encourage that type of payment system. Keep in mind that this funding is currently authorized but not appropriated. So we do need to push the actual appropriation of this funds. And we believe this is going to be very relevant for our clinics because it will provide funding for health outreach and for community health worker staff and those kind of activities. So we think this is a very important recognition in national healthcare reform that we hope will be able to advance further use of community health workers and the promotora model. And we agree with you that that's very important for being able to address the broader psychosocial needs of our patients. And we believe community clinics have been leaders in that, and this will facilitate that further.
I would like to go ahead and add to that by letting you know that the Community College Chancellor's Office has been in discussion about allocating specific dollars for to go out competitively to our campuses to ask them which of the entry-level health profession programs they would actually double partner as promotoras programs. So they would the students would actually be educated in the community college as to do that to take that role, and that would be in the next fiscal year.
Mm-hmm.
So,
well, thank you for your points. One of my other concerns is obviously the funding that needs to get down to the locals, and the questions become how do we ensure that the dollars do get down to the locals. I've had the privilege of working with different promotora groups throughout the state of California, and even creating our own promotora model for the clinics that I used to work for. Funding is always the issue, and you're right. It's always they're always the first folks to go whenever there's a lack of money. And for the most part, promotoras are usually volunteers, stem from our own communities that know each other. Right? They're comadres, they're compadres, they're our neighbors, they're our parents. And at the same time, those are the folks that are most trusted in our communities. So I definitely see the link here as to how this can be an empowering model to improve the quality of life for all our folks. But my other concern is just ensuring, and what perhaps the state legislature can do to make sure that those dollars get down to our nonprofits, to our promotora programs on the ground, right, to our clinics, as opposed to them staying up here in Sacramento. Although I can appreciate the hard work that our agencies can be doing here at this level, but quite frankly, at the end of the day, we got to get that work out at home.
So that's why I'm enthusiastic about being in the community college programs, because number one, that will go to a number of local partners, local areas, and having it institutionalized in the academic system keeps it from being just a volunteer informal. You're double skilling somebody to have a paid position, but as well have the community outreach. So.
Well, this goes to the points I raised at the conclusion of my presentation, that I do really feel that what you're saying is so important, because the state might have be the one designated to actually bring the money to California, but there are many instances, and this would be one, where the state does not have an infrastructure or staff or do not have community health workers. So the only way that if the state's a dollar is going to flow through the state, they're going to have to be subcontracting with the community organizations in order to make this happen. And as I mentioned, we have found that there are currently some barriers to the state being able to get these proposals out in a timely fashion, work in a workable and clear process to subcontract with the private nonprofit sector. So as I mentioned, we're working with Dr. Horton to attempt to address these issues, but it may be of interest to the legislature to assure that these barriers are removed, taken care of in a timely manner, so we can do exactly what you said, get the dollars down to the community.
I'd love to be part of that conversation, and maybe even for the next year, like to see if that's an idea for a bill.
We'd love to work with you on that.
One additional point I'd like to make is that 60% of the funds that come through the application that the California Workforce Investment Board receives, the monies they receive, they can reallocate up to 60% of that to the local levels.
Well, thank you for all that, and Mr. Chair, thank you for allowing me to ask these questions.
Any other further questions from any of the members? I apologize. Kind of came at the... All right. Thank you very much. I appreciate all your presentation.
Ladies and gentlemen, just another reminder to have your electronic devices on silent for me, please.
Good morning.
morning.
Good morning.
And well,
Good afternoon.
well, let me rephrase that. Good afternoon by 15 minutes, and welcome, and
No
it's a
problem.
pleasure to have you here.
Thank you very much for inviting us to present. Before we begin, I'd like to address the last question that Assemblymember Perez raised, because it has been also a passion of mine for many years. In my spare time, when I'm not doing health workforce diversity and related development, my work is involved in pushing nonprofit hospitals to invest more in primary prevention. And health reform has created an immense opportunity, and I'm working with a variety of health systems around the country who recognize that the era of fee-for-service is coming to an end, and they're going to begin to be held responsible for the health of their populations. So those with the vision are recognizing that part of building that healthcare team that we're talking about has to include, whether it's promotores in the Latino community or community health workers in other communities. It's fundamental to how we address the health needs of the communities. So the good news is it's happening more and more, but we need to really intensify that work here in California. So we're here as the last speakers to make sense out of this largest and most complex sector in our largest and most complex state, to say, how do we do this in a more comprehensive and strategic way? How do we not just look at health reform as the sole focus, but really think more broadly about how we address our current workforce needs and build the infrastructure we need in an ongoing way to address those needs in the coming years. In addressing that, we have a number of slides that we're going to move through very quickly. And the first set of slides, I want to do a brief introduction of the California Health Workforce Alliance, which a number of speakers have referenced in the course of this hearing. The Alliance is the outgrowth of the work that my colleague Jeff Oxendine and I have led for most of the last 5 years, that was called the Connecting the Dots Initiative. And it was a statewide initiative funded by the California Endowment that focused on strategies to increase health professions workforce diversity in California. We found a variety of things in the course of that work. First and foremost, that there's an immense amount of innovation going on, but there's not a lot of traction, not a lot of institutionalization of those efforts. But in the course of that work, what became clear in the many linkages that we established with a variety of stakeholders and in the variety of recommendations that came forward, that we needed to have a mechanism to really begin to move forward and solve near-term problems, but at the same time build the capacity to move this agenda forward in a more substantive way in coming years. So while diversity is not in the title of the Alliance, I would emphasize that it is a fundamentally central part of the work that we do. I appreciated hearing from all of the Assembly members the recognition that diversity is a fundamental issue. In essence, in the Alliance, we say the demographics are a reality in California. It's really about investing in the people of the state of California. Do we want to import our providers from other countries or other states, or do we want to invest in our own communities? So that's really a core tenet in our work. See in the next slide an example of the partners. There's over 100 organizations that we are partnering with as part of the Alliance. It is fundamentally a public-private partnership. There's a list of our steering committee members. The intent with the establishment of the steering committee of the Alliance is, in essence, not to create seats for vested interests, but to make sure that we have the breadth of expertise from health professions employers, from all forms of education, from K through 12 to higher education, from federal, state, and local government, and from constituency organizations representing a range of projects, advocacy groups, and the like, that all of these folks needed to be at the table. So we have 4 quadrants of representativeness, and we have representatives from each one of those 4 quadrants on the Alliance. a variety of roles and functions that were intended and are in the process of being further developed with the Alliance. Incidentally, the Alliance was launched in June 11th of 2009. We just celebrated our first year anniversary, and we're very excited about ways in which we can operationalize so much of what has been developed in the context of health reform. Write that down. That's the web address for the new site for the California Health Workforce Alliance. It's an important mechanism. The website is live today, but over the next 2 weeks, we're going to be bringing in reports, studies, project descriptions, innovations, a variety of information from not only on behalf of the Alliance, but on behalf of all of the partners in the Alliance. There's also social networking software on there, because the intent here is to make sure we have the opportunity for day in and day out dialogue among all of the members of the Alliance. So that's an important part of that work. Brief list of the core priorities for the Alliance. Again, this is a very large issue. I think it's a similar dynamic we face in health reform, is that we can't take on everything at once. There are elements of everything that we need to be giving attention to, but we have got to give some particular attention to some of these areas. And again, I won't go into each of these at this juncture, but we may come back to them, particularly in addressing questions. I want to turn it over to my colleague to talk about some of the lessons that we have gained thus far, particularly as it applies to taking a statewide strategic approach to health workforce development.
So we have the opportunity in our state to learn from what our colleagues experienced in Massachusetts with health reform. As you know, in 2006, they enacted health reform, which resulted in about 400,000 Massachusetts residents gaining coverage that didn't have coverage before. That's a small number compared to what we're going to be looking at here in California, but still some valuable lessons. They did not do any workforce planning ahead of time, nor did they relook at their delivery model, which are things that they're suffering from now. They did, unlike us, they had an ample supply of physicians, and they had more ongoing workforce development efforts further along than we do here. In fact, they had some of the highest PCP to population ratios in the country, yet they still had severe primary care access challenges when people were covered. As we know, coverage does not equal access, and so much so that some of the state senators there felt that health reform overall was threatened by not having a sufficient primary care and other health workforce in order to meet the increased demand. And that's something that we need to be proactive about and not allow to happen here. The most significant impact of health reform on workforce in Massachusetts was in the community health centers, no surprise, and in the other safety net providers. As a result of the challenges in 2008, there was legislation passed to create a Massachusetts Health Workforce Center, and provided some funding to have a 16-member council that would coordinate health workforce efforts, although primarily focused on primary care, because that was the most immediate need. And then that council worked with the Bank of America, the Partners Health System, and some of the other major private players to put together a very successful primary care initiative, a public-private partnership. And the first tenet of that was a loan fund. The Bank of America itself put in $5 million to support. So going to industry and convincing them that this is part of their agenda was important. And the result was having loan forgiveness and scholarship programs to encourage people to stay in primary care, and particularly to work in community health centers. And within 3 years, they have estimated 101 people have received those funds, are working in community health centers that may have not before, have increased access for about 144,000 people that didn't have it before by virtue of having that program. So that was a successful program. I think the impact on other health professions has been somewhat masked by the economic downturn that, as was mentioned earlier, many of the nurses and others planning to retire had not retired yet, so they're not experiencing as great a shortage there, but they are concerned going forward, and they have significant coordinated allied health, nursing, and other health workforce efforts that are underway in that region in a partnership between the Workforce Investment Board and the private sector players there. One thing that we did learn there is that having a council alone is important, but it's not sufficient really to have an implemented plan and have a sustained effort in this particular area. The council could make some recommendations, but there needed to be other public and private entities to execute and to do the work. So those are some of our lessons from Massachusetts. Other states have also addressed, that haven't had health reform yet, but that were being proactive about health workforce, also developed some more statewide or really major regional initiatives. One that we've modeled the alliance after is in the Pennsylvania and the Delaware Valley, the Life Sciences Careers Alliance, where they brought together not only the workforce investment boards, but the biotech industry representatives, pharmaceuticals, all the major health organizations, as well as the educational institutions and K through 12. So they had all the players at the table. They have one identified place. They work closely with the state agencies on workforce data and planning and training. And they've, by virtue of having one clearly defined leadership entity, they've received a lot of federal dollars, and people know that's the place to go in terms of supporting and coordinating around health workforce efforts. North Carolina has an incredibly robust statewide health workforce commission and health workforce efforts. They really invest in the people of North Carolina, and that's been a long-standing issue there. I think they're one of the best models to look at. The state of Washington has a health workforce shortage task force coordinated through its workforce investment board with other private players, and a very successful one in the Northern Virginia area, that both public and private partnerships looking at health workforce. So these are things that we can learn from and do apply here in California. One of the things we were asked is, so how do we best meet our workforce needs here, and how do we best prepare for health reform and leverage the workforce funding that's available? So our approach is that we really need to create a major California health workforce initiative, which is a collaboration between the public agencies and many of the other organizations that spoke earlier with the Alliance, and really have one, not parallel, effort that is a comprehensive collaborative approach to developing a strategy for the state around health workforce. In particular, as was mentioned earlier, the need to have a unified vision for where we're going and some steps, long-term steps of how we're going to get there, and really not only develop that plan, but to be able to execute it and implement it, because that's how you really get results. The need for this here is in California. With the growth of our population, the aging of the population, the increased rates of chronic disease, we have a real perfect health workforce storm here, and we're going to have increased retirements. Again, the economy here is masking what our really health workforce challenges are going to be going forward, and we need to be prepared for that. In order to successfully implement health reform, we're going to have the workforce we need. Health is critical to our economic future here. And right now we have a lot of efforts going on, but they're pretty fragmented, they're underfunded, and they're not to scale. And so I think the key here is that while we need to be able to respond to these immediate health reform efforts, we also have to have more deliberate long-term plans in place. And we need to work across sectors to increase the pool of the health workforce that is available for the safety net as well as for other types of organizations. As CMS says, the 2014 begins now, so we really need to have if we're really going to have transformational health workforce changes, we're going to have to start now. You heard earlier about the significant barriers and policy changes that may be needed in order to get the workforce that we need and get people into these professions. And we need to start now to be able to do that. And again, we need to have expertise and infrastructure to be able to develop both statewide and regional plans. These are some of the priority areas that are identified as shortages, although I would have to say right now in our state, I don't think we have a defined set of priorities of what are the health workforce priorities and what are the major shortages and what are the projections going forward. And that's something that we need to develop and have a plan to be able to address. Many of these areas are being covered by state associations, but areas like public health, where 1/3 of the state's public health department workforce is going to retire in the next three years. And we talked earlier about the different types of people that we need to go into public health. There's not a plan at this particular point to address those, and they need to be part of the overall solution. And there's a lot of things that can apply across professions, which is why we're advocating for a statewide coordinated approach. one of the key things, the devil's in the details when you talk about should there be a statewide plan of some kind and and what is a unified workforce initiative. So these are some of the things that we think are the major components, that there should be a long-term, whether it's 5 years or more, a statewide and regional strategy, and that should be developed through a really facilitated, evidence-based process. And that the result would be workforce priorities and a roadmap and an action plan. Not enough just to have some recommendations that these are priority areas, or which has been done many times to identify what the barriers are. We need to have a plan for how we're going to address it, and using limited resources, how we're going to invest in that over time. We need an infrastructure to be able to do this. We talked a lot today. Everyone talked about the importance of public and private collaboration. That takes a lot of work to make that collaboration happen and to make these initiatives come together and to get joint funding and leverage those funding. So one of the things that we really think it's important that we have a sufficient infrastructure with staffing, funding, forums to implement this and really execute these plans. We've got to continue to coordinate across all the different things that are going on in the professions and the regions. And then at some point, we really need to have an institutionalized commitment and some oversight to make sure that we're achieving the results that are required. I guess we really are looking at a plan where we have some strategic allocation of resources based on priorities. A couple examples of in very different areas. In Mexico looked at developing its tourist industry, large, complicated country. They set out and defined certain communities that they were going to invest in over time, and they built out and invested in that one community and then went on to the next, and then over time had a really robust statewide plan. We have limited a countrywide plan and results. And in our case, we need to be looking at the same kind of thing. How are we going to invest our limited resources in these different professions and in these different regions, because we don't have enough to do all at once. But if we have a roadmap over time and we see where we're going, we can get there and mobilize people to help us get there. We want the current stakeholder groups to continue doing what they're doing. This isn't saying that there's one entity that's going to take over all this work. The Hospital Association, the Primary Care Association, the Nursing Association, the WIBs, we need to have them continue the great work that they're doing, but there needs to be a place where it all comes together and a public-private forum for setting priorities and collaborating and make sure there's not duplication and really leveraging resources. And then I think we need to really try to invest in and increase the scale of successful programs that we have already as part of the plan, and make sure that this is an initiative that has continuity during the transition to a new administration that's going to be coming up. And that it's we think this initiative should be part of health reform, but it should be independent from health reform, because this kind of health workforce transformation is needed regardless of health reform. Health reform is hopefully a great catalyst to help make it happen. So why do we think this needs to be a public and private approach? Because it might be tempting to say, well, we've got a great workforce investment board, we've got OSHPD that's doing an outstanding job. Why don't we just use the current structure that's in place? Well, we think that there's a lot of strength that is provided by that structure, including and by the legislature, including the authority and the resource commitment and the administrative leadership, the expertise in the programs that are in place, the access to federal funding, and really the ability to institutionalize and sustain commitment. But at the same time, I think there are some challenges, and by working with the private parties, there can be sometimes more flexibility and dexterity to move quickly, to get things done, to convene folks, to hire people, to get contracts out, as was referred to earlier. There's good content expertise and industry-driven knowledge on the private side. There's additional funding sources. There's the amount of money through the state and through the federal system is not going to be enough itself to really do this work. So we need to leverage these other players, and we're not tied to some of the political and budget challenges, and we can also generate some good policy issues for all of you. So I think if we have one combined approach, which is what we're saying, I think we'll be stronger and develop more resources and be able to get a lot more done. These are some of the elements of what this initiative might have. It's some kind of a leadership council. The public and private stakeholders should be created. There needs to be underneath that group really a planning and implementation group of some subset of organizations, some kind of an organizing intermediary to coordinate among the different players and to provide a forum for that collaboration and to do some of the really hard work that needs to be done. The agencies will lead their work, the sectors will lead their work, and the professions. And then there needs to be regional initiatives linked with a statewide strategy and, of course, legislative leadership and oversight. And I think altogether, if this is the defined way that California is going to approach it, we'll be more successful. As I mentioned, we can't just look at health reform for funding sources. We need to look at all these different types of funding sources and be creative and have a way to receive those and leverage those. And then these are the different phases. Where we are now is we're organized. We need to organize ourselves, organize the players, figure out what the process is and the funding. A real key thing is to respond to the immediate grant opportunities that are there and make sure that the right players know about those. We have the right champions in place, and we're pursuing those. But we also then need to get on with the long-term assessment and more facilitated planning. We need to agree upon some initial plan and priorities and then execute them. A lot of this is going to be in how well it's executed, and then realize that it's going to require ongoing coordination and adjustment and having a forum for doing that. So that's sort of our overall vision of how this can come together. There's a lot more detail that we're working with our state partners on how to flesh that out, and would also welcome more dialogue with you. And Kevin will now finish by telling us how he thinks we should move forward.
So, few words on the most immediate federal health reform grants requests that we have out there. First, as is typically the case, it is a very compressed time frame. There are a series of about 5 grants that need to be submitted in less than 3 weeks from now. One of those is the planning grant, but a number of them are for major allocations. And so what do we have? We have it's basically it's framed as a competitive model. It puts smaller entities at a disadvantage. It tends to foster an institutional focus. So basically, how do we get these dollars that we need and do more of what we currently do the same? So there's no consideration of regional needs, no leveraging of the resources of the institution, no challenges to say, how does this get institutionalized? Now, to the credit, I think, of some of the applicants, they will on their own think of some of these issues. But the way that the current model is, and one of the challenges that we face is how do you do this in a thoughtful way, and how do you really do it with the particular current and projected needs of your region in mind? It tried to distill out here really what's needed, and it's been touched on by a number of folks, but just focus here on what we need to really understand what our current capacity on the supply side, what are our current needs. And putting the two together will give us a gap analysis that we need to really assess how far we have to go. And we need to select some of those priorities that we're going to focus on first. Not that they're more important, but they're more immediate, and the opportunities present themselves for focusing. And as Jeff said, you have a roadmap that leads you to the others that you want to focus on down the road. Then we've got, as a part of this process, to identify the obstacles. I'm going to identify a couple of those in a moment. That have already emerged in the course of discussion. You've heard about at least one of those already today from Carmela Castellano. But we have to really begin to project future needs based upon demographic trends and emerging models of practice. Assemblymember Perez talked about the need to use promotores, the broad spectrum of teams that are involved. How do we use telemedicine? How do we use a range of mechanisms to help address these needs? Because the general understanding that I hear from folks in the field is you're not going to get that many primary care physicians to move to a lot of these rural areas. We've got to be creative about how we address those needs. At the same time, we push to do that. Then at the regional level, we've got to really identify who's at the table and, by extension, who is not, and what are the roles and contributions of those stakeholders. One of the things that we have found across the state is there are ample examples of individual hospitals, health plans, and others that are doing terrific work in their communities, and we need to use their examples to drive change with other organizations. So basic elements. First, get the facts, and we need to get those facts now. The data that we have is far less than perfect. We don't need to wait for perfect data, but we need to focus our efforts. Really think about pathway development. Was presenting at a conference in New Orleans a couple weeks ago when there were a couple federal officials they were amazed that we were looking at K through 12 because a lot of people just look at this as near-term placing people, particularly in the allied health professions, into jobs. They're not thinking about how we need to look at strategies to reform and strengthen our K through 12 system in the process. Particularly important given in California, where we have in the urban and rural areas fundamental inequities in the way that these kids are prepared. We've got to find ways to invest more and help support our health academies, help establish linkages, establish the kind of accountabilities that are needed. As referenced by Stephanie Leach, we've got to look at how we align pre-health curricula across our institutions, strengthen the articulation across higher education. There are a number of specific recommendations that have been put forward that are being discussed, such as establishing a joint health sciences committee that brings together the UC community colleges and CSUs and other health professions education institutions to really think through how we really coordinate these efforts across these institutions. And then is the strategic engagement element, how we really bring folks together at the state and regional level, look at how do we codify some of the kind of roles and responsibilities we're talking about with regional MOUs. A good example of a number of entities down in San Bernardino area between the CSUs, employers, Western University have established regional MOUs to really channel health science students through those programs. We need to take these kinds of examples and build on them. And we do that through rapid dissemination of the kind of innovations and direct technical assistance to move that agenda. Last but not least, and this gets to the core question that you folks asked at the outset, which is, what can the legislature do to help move this agenda? There are an array of obstacles that have been identified both today and in the course of our work in the California Health Workforce Alliance. One of those is how do we institutionalize innovations? We have the University of California that is a publicly supported institution. It's a land-grant institution. It has fundamental responsibilities to prepare, educate, and place graduates in practice in our communities. We need to look at how we really institutionalize the many innovations that faculty and staff have developed in institutions like the UC. How do we make sure that there is the core line item funding that they need? Because like so many of the kind of innovations that we're talking about, it is often these innovative programs that are the first to get cut, and we've got to find a way to make sure that we support that. Look at ways of improving data collection. Dr. Carlisle mentioned the SB 139. There are a number of entities that are still not effectively cooperating and providing the data that are needed to effectively implement that clearinghouse. That can and should be addressed in the legislative arena. On scope of practice, there are a number of issues around how we make sure that we have the workforce that we need at all levels, and there are ways in which the legislature can effectively address that issue as well. Educational modalities, and that gets at a number of folks have identified that in a lot of higher education we put time-based parameters around the education, and that we need to move towards competency-based parameters. And the legislature can help facilitate that kind of process through its input. And last but not least, on the issue of accreditation, one of the issues identified along the way is that we have a number of our investor-owned training institutions, particularly in allied health professions, have stepped into to help get more folks with the kind of training that they want and need to enter the allied health professions. Unfortunately, to a significant degree, many of these come out with large debts and find out that they don't have the competencies that the hospitals and other organizations need in their process. That issue has to be addressed in a more formal way to ensure that we have that accountability. And last area fundamentally is how in the process we build state agency capacity. Our interest is in looking at ways that we can begin to integrate more fundamental planning functions into core state funding for the Office of Statewide Health Planning and Development. How can we codify interagency coordination in a way that it transcends administrations so we can be ensured that this kind of active coordination is in place? And in fact, that's a factor in the appointment of leadership for the respective agencies for incoming administration, and how we begin to build and expand the expertise in our workforce investment boards who have the charge of dealing with all sectors and have had an orientation, at least historically, of focusing on operating one-stop centers and channeling people the lower end of the economic sector into jobs, an absolutely essential role. But we're asking them to participate in a highly complex endeavor that really requires a much broader range of expertise and resources than are currently in place. And we hope in the process of doing this work to help strengthen their function in that regard. And last but not least, in general, is to how to really solidify an ongoing coordinating structure between the public and the private sectors. Thank you very much.
Thank you. Let me ask you, based on your experience in helping other states deal with this workforce issue, what do you think California most needs to do to implement real policies around the issue?
I think we need to do what basically is taking place right now, which is beginning to look at how the public agencies can work with the private industry partners that are out there doing the work, and sit down and roll up our sleeves and say we need to develop a longer-term plan. We need to have some immediate priorities, but it's a lot of dialogue, I think, that has to take place in order to come up with where are we going to focus and what are the most important ones to start with, and what do we do over time? Because there's a myriad of issues, and the issue is getting some clarity and agreement amongst the key players on where to start and how we're going to move forward.
Okay. You also made some comment earlier about the Health Workforce Master Plan, and I'm sure you're very well aware that this is something I've been working on since I got in the legislature. It's unfortunate that the first bill didn't make it out of appropriations, and even more unfortunate that the second bill didn't get signed by the governor, but, I'll continue to bring it back. But you had mentioned the Health Workforce Master Plan, and also referencing how I think it was on the East Coast with Massachusetts that couldn't, even though they passed the legislation, couldn't actually get it implemented because of the lack of access. But how do you think California should look at either continue to do a master plan and or a commission, and should it be done statutorily to have a commission to start addressing these questions? Because I don't think it was addressed on the legislative portion or the policy solution.
In my view, having a formal commission serving a role to help help tee up and address the policy issues is important. I mean, you have far more expertise and understanding of the terminology and the mechanisms for doing that in the public sector. I think our interest is in seeing that happen in the manner in which it is viewed as most appropriate and most productive on behalf of both the legislative and executive branches. But it needs to occur, and there needs to be a formalized structure that is coordinated, so we're not working at cross purposes between the two branches of government. My experience with stakeholders in education and in industry, they're really seeking clarity on how best to move forward. They often need to be pushed in directions. I think one of the real benefits that we've found in the course of the work of the Alliance, and we're still in the early stages, is they're gradually working towards people speaking more and more the same language, and finding common ground on things that they didn't envision finding common ground on, because we've tried to reduce the dialogues to how we solve problems and keep people's eyes on what it is that we're trying to accomplish. And again, doing so in a way that doesn't juxtapose each of the stakeholders as representing my organization or my interest, but rather how we bring our expertise together to solve problems.
Also, just to add, I think a council or commission is necessary, but it's not sufficient. because I think there needs to be, in addition to having those recommendations made and decided, there's a lot of work that needs to be done in order to be able to get there. And the work has to be not only done with all these multiple stakeholders, but then be able to again, have this ongoing coordinating infrastructure to implement the plan that is developed. And to adjust it as we go forward, and to respond to these different kinds of opportunities that come up, and to really make this a long-term, sustainable initiative. And the council can be a key part of it, but there needs to be other levels of people to do the work.
Okay, thank you very much. I appreciate it. I'd ask other questions from other members, but unfortunately there isn't any other here.
No problem.
What I'd like to do at this time is I'd like to open up the public comment, if we can hopefully get anybody who's interested. And if anyone would like to make any public comment, please do so up here. Well, it doesn't look like there's any interested individuals. What I'd like to do at this time is, first of all, thank everyone in the audience for being here, for taking an interest in workforce, especially with regard to health care. But most important, I'd like to also thank the presenters for taking time out of their busy schedule to come up and give their presentations. I'd like to apologize because unfortunately I missed, I think, the first half of it because I was unfortunately held up in some committees that I needed to present some bills. But I'd like to just kind of close with these comments that this is something that when I got elected to the State Assembly that I was very interested in. First, my interest was obviously in health care reform. But then I soon realized that if we were going to have any kind of health care reform, this is probably the most important thing that needed to be addressed. I understand that it's an extremely complicated issue. We have to deal with, with the private sector. We need to deal with workforce. We need to deal with a master plan. We've got a lot of at stake when we are dealing with our health care reform. But this will continue to be one of my priorities, and I'd like to just close by thanking everyone for being here, and I will continue to work on this issue, and hopefully we can address it. And thank you very much.